This peer-reviewed article outlines how custody nurses should assess and manage patients experiencing opioid withdrawal in police custody. It is written by Matthew Peel, Advanced Clinical Practitioner, Police Custody, Leeds Community Healthcare, NHS Trust. It is read to you using an automated voice, so some of the words and phrases may not be as you would usually expect to hear them. The full version of this article, with citation, references, and illustrations, can be found at nursingtimes.net under the Prison and Custody category. Subscribers to Nursing Times have unlimited access to all our current and archived clinical articles, including a range of online learning units on fundamental aspects of nursing to contribute towards your continuing professional development and revalidation requirements. Introduction. Individuals are typically detained in custody for a relatively short period, less than 24 hours. Opioid withdrawal is a common condition seen in custody because of the well-documented relationship between opioid dependency and crime. But opioid withdrawal, while typically an unpleasant condition, is rarely fatal. This article will focus on the assessment and management of opioid withdrawal in police custody, which is often carried out by custody nurses and paramedics, hereafter referred to as healthcare professionals, HCPs. It will also discuss the background of opioid dependence, stigma, pathophysiology, signs, and symptoms. Opioids are known for their potent pain-relieving effects, and the term opioids encompasses natural opiates, as well as synthetic and semi-synthetic opioids. Throughout this article, opioids will be used to encompass all. Background. Opioid misuse is usually thought to include those who inject or smoke heroin, those who are homeless, and those who offend to fund their addiction. However, individuals may misuse diverted opioids, that is, imported opioids or opioids that are prescribed legitimately but illegally distributed for non-medical purposes, and develop dependence without injecting or smoking. Additionally, individuals can become dependent by being prescribed opioids, be they used as directed or misused. The latest estimates between 2019 and 2020 show there were 293,863 people misusing opioids in England alone. According to the most recent figures, between 2023 and 2024, there were 137,965 adults in treatment for opioid use in the community in England, of which 21,142 are in prisons. All are at risk of opioid withdrawal. Those with opioid dependency, particularly those who inject, experience mistrust, marginalization, stigmatization, dehumanization, negative comments, and differential treatment by HCPs. All those dependent on opioids, but especially those who inject them, are considered aggressive, dishonest, manipulative, and uncooperative. Rees, 2022, noted that custody nurses considered such individuals as being manipulative, drug-seeking, and high-maintenance. Addiction is among the most stigmatized of medical conditions, with society often misinterpreting drug use as a deliberate choice and ignoring the underlying factors. The language used when discussing individuals with addiction greatly influences their self-perception. The incorrect use of language leads to both direct and systemic discrimination. In custody, where people are particularly vulnerable, using dehumanizing language can worsen the distress of opioid withdrawal. To help change these perceptions, HCPs can alter their language and instead use non-stigmatizing, person-first language. An example of this would be to say, person with a substance use disorder, rather than addict, to create a more respectful and supportive environment. This change can reduce stigma, foster empathy, and encourage individuals to seek help without fear of judgment. Opioid dependence can arise from regular opioid use or misuse, with the timeline depending on factors such as dosage, formulation, immediate or long-acting, frequency, route, and individual susceptibility. Although the definition included in the World Health Organization's International Classification of Diseases states usage as being for a minimum of 3 months, the National Institute for Health and Care Excellence, NICE, warns that dependency can develop in 2 to 10 days. Opioid withdrawal is a consequence of abrupt cessation or a marked reduction of opioids in those who are dependent on it. Opioid dependence develops due to sustained exposure to opioids that suppress the production of neurotransmitters such as norepinephrine, also known as noradrenaline. This leads to tolerance and physical dependence, necessitating higher doses to achieve the desired euphoric or analgesic effects. When opioids are abruptly reduced or stopped, noradrenaline is no longer suppressed, leading to a surge. This so-called noradrenergic storm causes the withdrawal symptoms. Signs and symptoms. Opioid withdrawal is characterized by physical and psychological signs and symptoms, an illustration of which can be found in the article online. The degree of symptoms is not only dependent on the type, quantity, and frequency of opioid use, but is also influenced by psychological factors such as stress and anxiety. Assessment. Opioid withdrawal should be suspected in anyone presenting with any of the signs and symptoms as outlined in the online article, who reports a history of opioid misuse or is taking regularly prescribed opioids. HCPs must appear non-judgmental and avoid labeling patients as drug-seeking. Ideally, those at risk of opioid withdrawal should be monitored regularly, 3 or 4 times a day, or more often, in those who are unwell or have serious medication conditions. As a minimum, someone presenting with or complaining of opioid withdrawal should have a multi-drug urine screen and routine checks of the following vital signs: pulse, blood pressure, respiratory rate, temperature, consciousness, pupil size. The Clinical Opiate Withdrawal Scale, which is produced with the article, is one of the most universally used tools to assess opioid withdrawal and is recommended by the Clinical Guidelines on Drug Misuse and Dependence Update 2017 Independent Expert Working Group. While not diagnostic, the Clinical Opiate Withdrawal Scale can help quantify the severity of opioid withdrawal and track response to treatment. The tool uses a mix of subjective reported symptoms and objective clinical signs. The Royal College of Psychiatrists and Faculty of Forensic and Legal Medicine argued that greater weight should be given to objective signs over subjective symptoms. Management. The main treatment for opioid withdrawal is an opioid substitute. However, other pharmacological and non-pharmacological options may help. Pharmacological management. Pharmacological treatment can be divided into that which is opioid and non-opioid. If there are no clinically objective signs of opioid withdrawal, using antiemetics, antispasmodics, and simple analgesics for symptomatic relief may be suitable. However, if objective signs are present, symptomatic relief alone should not replace treatment with an opioid substitute. Opioid. Both methadone and buprenorphine are licensed for use as opioid substitution therapy, and, if already prescribed in the community, these should be continued where it is safe to do so. However, if not, dihydrocodeine is often used off-license in custody to treat opioid withdrawal. An opioid is indicated if there are no signs of concurrent intoxication, i.e. with benzodiazepine, and there is clinically objective evidence of opioid withdrawal. Methadone. Methadone is a pure opioid agonist, activator, with a slow onset of action and a long half-life, 13 to 50 hours. An agonist binds to a receptor and activates it, producing a physiological response. Doses start at 10 to 30 milligrams daily. These may be increased by 5 to 10 milligrams, with a maximum weekly increase of 30 milligrams to a maximum daily dose of 60 to 120 milligrams. Methadone's slow onset of action, long half-life, and gradual induction make it unsuitable for short-term opioid withdrawal management in custody. As a result of the long half-life, a particular worry is the effect of any additional opioids taken after release from custody, which could lead to overdose. Buprenorphine. Buprenorphine, Subutex, is both a partial opioid agonist and antagonist blocker, with a long half-life, 24 to 42 hours. Doses start at 0.8 to 4 milligrams, adjusted daily by 2 to 4 milligrams as needed to a target dose of 12 to 24 milligrams. Being a partial opioid antagonist, buprenorphine blocks additional opioids from activating receptors in the brain, spinal cord, central and peripheral nervous system, and gastrointestinal tract. However, this antagonistic effect can also precipitate opioid withdrawal if buprenorphine is administered while circulating opioids are present. Wesson and Ling suggested that a clinical opiate withdrawal scale score of greater than 24, moderately severe, is unlikely to precipitate an opioid withdrawal. However, delaying treatment until such a high clinical opiate withdrawal scale is reached is unsuitable because of the negative impact on fitness to interview. This, combined with the long half-life and gradual induction, makes buprenorphine unsuitable for short-term opioid withdrawal management when a person is in police custody. Dihydrocodone. Dihydrocodone is a semisynthetic, weak opioid analgesic used to treat moderate to severe pain. It benefits from reduced toxicity, a short half-life, 3.5 to 4.5 hours, and a rapid onset of action, 1.5 to 2 hours. Dihydrocodone regimens typically start at 60 to 90 milligrams 3 or 4 times a day, but it can be given every 4 hours. However, some individuals may need incrementally higher doses. Once started, dihydrocodone should be continued at regular intervals and not used as needed. Non-opioid. Pain. Regular paracetamol and ibuprofen should be offered and encouraged. Give 2 500 mg paracetamol tablets up to 4 times in 24 hours, with at least 4 hours between doses, not exceeding more than 8 tablets in 24 hours. Ibuprofen can be offered as 1 or 2 200 mg tablets or capsules 3 times a day, with 6 hours between doses. Caution is needed with high-dose or long-term use of paracetamol due to potential liver function impairment. Ibuprofen should be used carefully in patients with a history of ulcers or renal impairment, as it can exacerbate gastrointestinal and kidney issues. Diarrhea. Diarrhea can be treated with loperamide. Give 4 mg initially and a further 2 mg after every episode of loose stool to a maximum of 16 mg daily. Nausea and vomiting. Nausea and vomiting can be treated with buccal prochlorperazine. Place 1 or 2 3 mg buccal tablets twice daily inside of the mouth at the top of the gum. Abdominal cramps. Abdominal cramps can be treated with an antispasmodic, such as mebeverine, 135 to 150 mg, up to 3 times a day. Insomnia and anxiety. Reduced total sleep time and waking often are significant, yet often unaddressed, issues during opioid withdrawal and can worsen symptoms. Sleep hygiene advice, such as avoiding caffeinated drinks in the afternoon and also avoiding meals before sleep, may be helpful. The Clinical Guidelines on Drug Misuse and Dependence Update 2017. Independent Expert Working Group recommended a sedating antihistamine, such as promethazine, over Z drugs, such as zopiclone or benzodiazepines. Promethazine is an antihistamine with a sedative effect. Doses of 20 to 50 milligrams at bedtime are recommended. Any night sedation, including a patient's own, must be carefully considered. The HCP must be satisfied that the patient is not going to be interviewed or released overnight. The HCP should also recommend a suitable period of medical rest during which no police processes can take place until the period has expired. Anxiety is a significant feature of opioid withdrawal. The routine use of anxiolytics, such as diazepam, is discouraged, as individuals may be transferred to a prison with a positive benzodiazepine multidrug urine screen and receive an unnecessary benzodiazepine detoxification, thereby risking overdose. That said, anxiety and lack of sleep negatively affect mood and interview, and increase the risk of self-harm. Custody HCPs could mitigate the risk of unnecessary benzodiazepine detoxification by undertaking a urine drug screen before the administration of any benzodiazepines and sharing the results with the prison healthcare team. As benzodiazepines can negatively affect cognition, their use should be carefully considered, especially in relation to interview. Non-pharmacological management. As mentioned, anxiety is a major feature of opioid withdrawal. HCPs can play an important role in easing anxiety by listening to concerns, reflecting those concerns, making detailed assessments while being honest and transparent about any limitations. Again, it is essential that HCPs are mindful of their language and avoid statements such as, "You are not withdrawing," which only exacerbates anxiety, feelings of judgment, and stigmatization. HCPs would not say to someone, "You are not in pain," and the principle is the same here. While the HCP may not see any objective signs of opioid withdrawal, they should not discount what the individual states they are feeling. Indeed, early opioid withdrawal symptoms can be subtle and not easily detected through observation alone. HCPs should reframe their language, advising, "I cannot see any outward signs of withdrawal at the moment," while offering reassurances that treatment will be provided if indicated. Other measures include creating a calming environment, such as dimming lights and reducing external noises. Encouraging food, fluids, comfort measures such as blankets, and distractions such as books or fidget toys may also help. Complications. Opioid withdrawal is often said to be uncomfortable but harmless. However, this is not true, and opioid withdrawal can be fatal. As an example, 31-year-old mother of two, Judith McGlinchey, was transferred to prison with opioid withdrawal. Over the course of a week, her condition deteriorated, and she had a cardiac arrest and died in January 1999. Individuals particularly at risk are those experiencing prolonged or severe diarrhea and/or vomiting, making them at risk of dehydration, renal failure, or electrolyte imbalance, especially in those with concurrent illnesses or comorbidities. Dark et al. Highlighted 10 deaths in 3 years of people in custody in the U.S. due to opioid withdrawal, of which 6 were in females. This is concerning, as men are much more likely to be opioid dependent than women. It is not clear why more women died from opioid withdrawal. One explanation may be that women experience greater degrees of opioid withdrawal compared with men. Conclusion. Addressing opioid withdrawal in police custody is a critical aspect of providing comprehensive care. Given the prevalence of opioid dependence and its link with offending, custody HCPs need to recognize and manage withdrawal effectively. This involves not only pharmacological interventions, such as the use of dihydrocodeine and symptomatic relief, but also non-pharmacological strategies to alleviate anxiety and ensure the environment is supportive. The use of person-first, non-stigmatizing language is essential to foster trust and reduce the negative perceptions associated with opioid use. Regular monitoring and tools, such as the Clinical Opiate Withdrawal Scale, can help quantify the severity of withdrawal and guide treatment decisions. Understanding the pathophysiology, signs, and symptoms of opioid withdrawal allows HCPs to provide timely and appropriate care, thereby potentially mitigating severe complications such as dehydration and death. Ultimately, the goal is to balance individual needs with the custodial environment's needs, ensuring individuals receive humane and effective treatment. By enhancing our approach to opioid withdrawal management in police custody, we can improve outcomes for this vulnerable population and uphold the standards of compassionate care. Key points. Use of person-first, non-stigmatizing language can help foster a respectful, supportive environment. Regular monitoring using the Clinical Opiate Withdrawal Scale is crucial for assessing the severity of opioid withdrawal. Treatment should involve both non-pharmacological and pharmacological interventions, with simple analgesics, antiemetics, and antispasmodics used in support. Creating a calming environment by, for example, dimming lights and reducing noise can greatly reduce anxiety during withdrawal. Opioid withdrawal can be fatal, especially in cases of dehydration or electrolyte imbalance due to prolonged vomiting and/or diarrhea. The full version of this article, with references and illustrations, including the Clinical Opiate Withdrawal Scale tool, can be found at nursingtimes.net under the category Prison and Custody, along with our AI search facility, Ask Nursing Times, which allows you to explore the subject further. Thank you for listening